Hi everyone, and welcome to the Otolaryngologic Clinics podcast. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the June 2021 issue dedicated to modern approach to the salivary glands, guest edited by Drs. M. Boyd Gillespie and William R. Ryan. Here now is a consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today, I have the pleasure of speaking with the guest editors of the June 2021 issue of Otolaryngologic Clinics on North America called Modern Approach to the Salivary Gland. The editors are Dr. M. Boyd Gillespie, who is professor and chair of otolaryngology and head and neck surgery at the University of Tennessee Health Science Center in Memphis, Tennessee, and Dr. William Ryan, who is associate professor, head and neck oncologic, endocrine, and salivary surgery in the Department of Otolaryngology, Head and Neck Surgery at the University of California of San Francisco in San Francisco, California. Welcome, Boyd and Will.
Thank you.
Thank you.
As we all three pointed out in our forewords to this issue, the salivary glands can be viewed as the unheralded workers of major life and quality of life functions. We ignore them, and then something goes wrong, and suddenly there's a severe dry mouth or swelling in the cheek or the upper neck or the floor of the mouth, and we suddenly are alerted that they exist and they do something important that they're no longer doing. I have to commend both of you. You've put together a thorough compilation of articles that cover the breadth of how we assess and treat conditions of the salivary glands. I really like that you subdivided this issue of clinics into three sections: basics, then surgical techniques, and then salivary malignancy. And I think it's a very logical way for the reader and the practitioner of otolaryngology to look at these conditions. So this issue and all issues of Otolaryngologic Clinics of North America can be found at www.oto.clinics.com. And that's where our listeners can find this and previous podcasts, and they can find this podcast wherever they get their podcasts. So let's go over some of the highlights of each of the articles. It starts in the basics section, and in the article by Drs. Chang and Zhu on ultrasound for salivary diseases, they advocate for surgeons to be the ones performing the imaging study. They've provided beautiful images of systematic ultrasound examination of the major glands, the neck, and the lymph nodes. I really recommend that our listeners go back and take a look at them because it's just a very thorough approach where things will not be missed. So Boyd, let me start with you. Do you personally use ultrasound in your practice, and how helpful is it in your day-to-day?
Thank you, Sujana. I actually do use it in my practice, and it's something that I learned from European practices. Ultrasound is the dominant form of imaging for a lot of forms of head and neck disorders in Europe. And I think it's a little bit late to be adopted in the United States, but hopefully now more residents are getting exposed to it and more people are having it in their practices. And the major reason to have ultrasound in your practice is a convenient point of care for the patient. But the salivary glands are fairly superficial structures. You can image them very thoroughly with ultrasonography, whether it's tumors or other benign or inflammatory conditions. And the thing I like best about it is that it allows functional imaging of the glands. And I do believe that surgeons need to be familiar with this because although radiology clinics do a good job with thyroid ultrasound, they may be less familiar with the salivary glands. And in my office, I actually keep a bag of sour candies, and I'll do functional studies and have patients suck on these things prior to studying their salivary glands. Normally, a salivary gland should empty instantly when given something sour. But if you see the gland become congested, you know that there's a blockage. And you can often see these dilated ducts and follow them to a pinch point, which is the pathology, whether that's a stone or scar. So, and you won't get that from a CT scan. You might be able to see a stone, but you'll certainly miss pinch points or scars unless you do a functional study.
That's really interesting. I know at the academy, those ultrasound courses are really oversold or oversubscribed as people are incorporating this into their practices. Will, what is a sonopalpation technique?
It's a technique, and it brings up the notion that surgeons have an advantage in using the ultrasound over a tech plus a radiologist reading a scan later, and that it's the transducer in your hands is an extension of your physical exam. It allows you to look deep to the skin and also deep to the mucosa in the situation of sonopalpation. So what it is placing a gloved finger into the mouth, either into the floor mouth or the cheek. You can press structures up or down towards the transducer and see them. So for instance, a distal duct or anterior floor mouth small silith may not be either palpable nor viewable by a transducer when you're just examining the neck. And by pushing that duct down towards the transducer, you can thus see the silith. And it's just a good way to augment your neck exam. The same thing can be done for the buccal area. And you can also see pinch points like Boyd was describing, and dilated ducts proximal to those pinch points if it's in a place where it wouldn't be obviously seen in the neck. So you're pushing mouth structures into view, basically.
Thank you. This article also talks about botulinum toxin injections of the salivary gland. So Boyd, would you mind commenting on when you might do that and how that's done?
Sure, thank you. Well, we've had experience with botulinum toxin for years. The main indication initially was sialorrhea. So we knew that it was safe. We would use it in pediatric cases of people with neuromuscular disorders who had hygiene issues that were not controlled. And we know that Botox works by preventing acetylcholine release that causes salivary production. So we can actually dry up the glands with it. It's been a helpful adjunct to people who have inflammatory salidinitis, whether it's due to obstructive causes such as stone or scar, or inflammatory issues like Sjogren's or radioiodine. Anybody who has a gland that gets congested and can't empty well, and that we, using conservative measures, can't get open. So people who don't respond to salagogues, heat, massage, antibiotics, steroids, or don't respond to salivary endoscopy, these are really blocked glands that aren't emptying well. And Botox injected under ultrasound guidance really kind of shuts down the gland, sends it into hibernation, prevents those obstructive symptoms and swelling symptoms and pain that the patient has, and allows the gland really to go under a natural involution or atrophy process. And that prevents us from having to go in and remove these glands. Removing these glands in people with inflammatory disorders certainly is much more difficult than other gland removal techniques and puts the facial nerve at high risk. So if we can avoid surgery by doing a chemical denervation, that's preferable.
So is it a one and done, or is it similar to Ritids? Does the Botox need to be injected a couple of times?
That's a good question. It is not always one and done. I would say in my experience, about half my patients will need one. We're using a lot higher doses than people do for Ritids. The safety dose has been described for per gland anywhere from 50 to 100 units, which is pretty convenient because Botox comes in a 100-unit vial. So typically we just mix 2 cc's of sterile saline in a 100-unit vial, and then we'll inject that over 2 to 3 sites. If I have 2 glands that are involved, I'll split it 50 units per gland. If it's 1 gland, I'll give it the full 100 units. So often that's enough to allow the person to have symptom relief. And I would put about 50% of those patients might need a second injection in the future.
Thank you. That's really helpful. I want to point out to our listeners that Dr. Zhu and Cheng have provided not only exquisite ultrasound and some MRI images, as I said before, but table 1 in this article looks at the advantages and disadvantages of various imaging techniques for salivary gland, and the box containing the clinical care points is really very helpful. So let's proceed on to the second article in the clinics. Dr. Sajid Sevi's article on the use of facial nerve monitoring during parotid surgery. I'm an otologist, right? So we're all about facial nerve monitoring. And I remember when the parotid surgeons started incorporating this in the beginning, they felt like, the monitor went off all the time, and it was almost more of a hindrance than it was a help. I wonder, Will, what do you think about facial nerve monitoring? When do you use it? Are there particular cases where you find it to be more helpful? What have you guys all done to make it not irritate you and actually help you during surgery?
Sometimes it still makes funny noises and has false positives, like you say. I've used it my whole career. I use it through training, and I use it on every parotid case. So I don't really discriminate. I think it's most useful in revision cases, and I think that's cited in the literature most often. I find it helpful, number one, for making the case actually more efficient, or I can have some assurance of making a cut a little more boldly, but it still isn't a substitute for anatomy and experience and caution. And so it always has to be used with judgment. I think it's useful in scar, like I said, for mapping out a nerve that may be encased in scar and look very similar to scar. And then if there is either an injury or, say, a situation where the nerve has to be removed for oncologic reasons, the distal point of the nerve can be mapped out nicely with the stimulator and the response of the electrodes to help for the reconstruction. So I think those are some of the uses. But finding the facial nerve trunk in the beginning, I find if I can insert the stimulator, find it, and it has a nice bold response, I'll know to dissect in that area more readily than a centimeter superior to that area, for instance. So and then that also instructs residents on anatomy and gives the whole case and the learners in the case feedback as to where the nerve is located.
Right, so you use it not just for patient safety and for efficiency in the operating room, but also as a teaching tool.
Yes.
Yeah, I like that. Table 1 in the article by Dr. Sajid Sevi shows those advantages and disadvantages in primary and revision parotidectomy, and that's actually based on the systematic review and consensus statement by Witt et al., for which our friend Boyd was the senior author. So it all comes around to Dr. Gillespie. Let's go to the third article in the basics section. And this is an article by Dr. Skillington and Ogan, and they present an overview of IgG4 related disease of the salivary gland. And in their box 1, there are 15 systemic diseases listed that fall into the spectrum of immunoglobulin G4 related disease. So Boyd, what are the key points of this article, and what are the important things to remember when this condition may be in the differential diagnosis of a patient?
Yeah, I think this is an excellent article. The IgG4 related diseases, we've just realized as a spectrum disorder. For many years, I think those of you in our age range remember having to learn about Mechlick's disease and Kuttner's tumor and Riedell's thyroiditis. Those are actually all part of the same process. And so these IgG4 related diseases, they're caused by activated T cells and plasma cells that exhibit IgG4 on the surface that actually invade tissues, which they have a predilection to the salivary glands, the lacrimal glands. It can be the thyroid glands. As that table shows, it can be anywhere in the body, the pancreas, the retroperitoneum, the mediastinum, and it creates an intense inflammatory and fibrotic response. The reason this article is important, I think, is that otolaryngologists, we're really the primary care providers for the salivary glands. So patients do present with these disorders, and they're typically enlarged, very hard, firm glands. They're painless, and so they're a little bit odd. They're not acting like someone who's infected. It's acting more like a tumor. And I think that's why the term Kuttner's tumor came about. And if you're not aware of this, you may misdiagnose these patients as having a tumor, may lead to unnecessary surgery. So you have to have this in mind. And really the key to diagnosis, as pointed out in this article, is good imaging first to rule out a tumor. And then secondly, getting a tissue diagnosis and asking your pathologist to actually stain for IgG4. You can also send a serum IgG4 level, which is elevated in about 50 to 70% of cases, but the tissue biopsy is really the way to go. But if you just treat it as a possible cancer and try to excise the whole thing, it may be a misadventure because these are very hard tumors and glands to remove, and they would put adjacent structures such as facial nerve at risk.
So when you get tissue, are you doing a regular fine needle aspiration biopsy? Are you doing a core needle biopsy? What's the ideal tissue to send, and how do you send it?
That's a good question. I think for this, you actually need at least a core tissue or even an open biopsy. So this is one where if you feel like you can get to it a core safely, that would be a safe technique. If you don't, it's just better to make a small incision and take a small piece. I'd be interested in Dr. Ryan's opinion of that, but is that your feeling too?
It's totally bizarre, but I did this today. I don't know. I mean, these are rare situations. I couldn't believe it was this morning, but it was for a parotid. It was a hard, firm parotid. I did a silendoscopy as well, which was pretty normal. The lumen of the duct was injected somewhat, but there wasn't any debris. And so I made a little preauricular incision about 2 centimeters, excise a bit of parotid, and let the pathologist know to stain for IgG4.
And that's our role. Our role is to make the diagnosis and then get the patient to the rheumatologist who does the primary treatment, which is usually steroids or some sort of anti-inflammatory, such as Rituxan or methotrexate.
Correct. And the rheumatologist had directed me basically to consider doing this, which I was already sort of thinking, but it was a nice collaborative thought process.
That's the best, right? When we're actually collaborating with our friends and our colleagues from other areas and kind of keeping that patient in the center, but doing really sort of cool things like you just described today. So we are done with basics, and we have talked about surgery because it's very hard to get 3 surgeons to talk to each other without talking about surgery. So let's talk about surgical techniques. The article by Doctors Joshi, Badger, and Benito is basically a primer on how to and when to do in-office sialoendoscopy. And they really provide like a primer, a complete list of the equipment that's needed, and then step-by-step instructions with pictures. I'm feeling much smarter having read through this issue of clinic. I'm feeling like I could actually accomplish something. And there are, of course, advantages and disadvantages to anything that we do in the office or the operating room. But you mentioned the sialoendoscopy on the patient that you saw today. Maybe you can talk to us about what the advantage and disadvantage are of what you find and don't find. And when should you not do this as a clinic procedure?
First of all, I do not perform in clinic silendoscopy. And I wish I could. It's a bit of resource allocation at my medical center and not being able to get a nurse assistant, I think, and to have a day in clinic in the procedure room. So it's a bit of a just a lack of resources. But I love that this exists, and I have extrapolated these types of articles and the data on them to doing it in the operating room under sedation, particularly in cases when a patient seems at risk for a general anesthesia for other comorbid problems. So, I mean, today I could have done that in the office, and that would have been nice for the patient. But I did a parotid biopsy, which I wanted to do under general. So I think first off, if one is learning sound endoscopy, of which it seems to be slowly spreading in its utilization around this country, predating us were the Europeans, who I think and even the Middle East, I think, has adopted sound endoscopy quite a few years before us. But I think under general anesthesia, when you're starting out, is probably the best thing to figure out when things are complex, how to predict that complexity or not. But I think simple, palpable siliths or something that can be performed in a clinic. I mean, you don't even need an endoscope, and we'll probably get to that with Boyd's article. I think diagnostic endoscopy, when it's not clear what the problem is, and you may not even intervene, but the clinic is a great use for that because it's very time considerate of the patient, and the patient doesn't have to have any anesthesia on board. That's when I wish I could use it, because some percentage of my practice, I don't know, maybe 20%, I don't actually know what I'm going to find. I don't have a lot of indicators objectively on ultrasound or other imaging or on physical exam, and it's just an endoscopy like it would be a colonoscopy or a nasal endoscopy. Recurrent disease, scarring, parenchymal disease, meaning not in the distal duct, but more upstream, we start thinking more towards a general anesthesia. And the article clearly indicates when and when not to, but that's just the way I think about it.
I generally think that most doctors, it's still pretty early in this country with salivary endoscopy, are going to do it in the ambulatory surgery centers or hospitals. And that's because you never know what you're going to get into. Something that looks fairly straightforward may not be straightforward. And it's nice to have maximum amount of tools at your disposal. Often you have to do incisional techniques, combined techniques, and that's certainly easier under general anesthesia. However, having this as an option as a diagnostic in your office, not a therapeutic, but a diagnostic scope exam, or as a follow-up scope exam for people where you already know their anatomy somewhat. I'm thinking of people with Sjogren's or radioactive iodine who have multiple scars and need follow-up dilations in the office and that sort of thing. This could be a helpful technique. So, but I do see this as for your more advanced users. So not the people who are just starting off, but people who have built up a practice and have patients, who return to them who they've already treated. So
that's a really logical way to look at it from both of you. You mentioned salivary duct stenosis earlier, Boyd, and you said that it's typically seen in general glandular inflammation, can be caused by a stone, can be caused by trauma, can be caused by autoimmune disease or chronic infection. And you, along with Drs. Reed and Hackman, wrote the article in this Clinics on open approaches to this problem. And I did note to myself that you incorporated the sialoendoscopy image of the pre and the post repaired Stenson's duct, and you showed this really cool technique of resecting the scarred duct and then making a tubular vein graft to repair it. It's really neat. Like, if the listeners are listening, it's cool to look at this technique. What are the pitfalls and possible alternatives to vein grafting when you have a main Stenson's duct or parotid duct stenosis, Boyd?
My first go-to is always going to be salivary endoscopy. So I think that we're able to take care of most stenoses successfully using sal endoscopes and guide wires and dilators and balloons. But you are going to have a certain group of people who just don't respond to that, who may need more open techniques. And whether or not they're a candidate for open techniques really based on where their scar is located. If it's in the interglandular portion of the gland, open techniques aren't going to work. Those are too small. Those ducts are too small. So you're really looking at the main Stenson's duct and the part that crosses over the masseter. If it's very distal, where it feeds into the mouth, often we'll just do a reimplantation of the duct. So it's really that mid portion of the duct that would potentially respond to vein graft. If the stenosis, severe stenosis, is less than a centimeter, often we can excise it and do an end-to-end anastomosis. If it's more than a centimeter, certainly a vein graft would be necessary. And the main drawback is that to do those techniques, you do have to have some training in microvascular techniques. You have to have a microvascular set. You have to have the proper microscope to do it. And I also think that it's a fairly rare need that we do this. Perhaps certain trauma cases we need to do it, but none of us have vast experience with it. We've all done 2 or 3 cases. So the long-term outcomes, it seems like these patients do pretty well in the short term, but we really don't know long-term if these vein graft ducts are going to stay open.
So do you then follow up, as you mentioned earlier, with either ultrasound or endoscopy? Like, how do you determine the longer term patency of this repair?
So yeah, I think some of it's just determined by the patient's symptoms. So typically, I would not do any further follow-up imaging or sal endoscopy unless the patient was showing signs of obstruction. They often don't. So that actually raises an interesting question. And we don't often know if a gland is functioning or not. So if a gland's asymptomatic, we're often very happy, but that may be because the gland is atrophied. So I think you had also posed the question, what if you don't have the training to do this sort of repair? Well, you could consider, if someone has an irreversible duct stenosis that you can't get open, you can always ligate the duct. And we do that in children. We have a long history with doing it. It does work. The people will have some obstruction for a period of time, but if the gland does not drain, there's a feedback mechanism that makes the gland less productive, and eventually it will atrophy. You may supplement that with some Botox to the gland when you tie off the duct to allow the gland not to become acutely inflamed while it's going through that natural atrophy, but that would be an option. So.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and I am speaking with the guest editors of the June 2021 issue of Otolaryngologic Clinics of North America on modern approach to the salivary glands. Doctors M. Boyd Gillespie of the University of Tennessee Health Science Center in Memphis, Tennessee, and Dr. William Ryan, who of the Department of Otolaryngology Head and Neck Surgery at UCSF in San Francisco, California. You can find this and all issues of Otolaryngologic Clinics of North America and all of our podcasts at www.oto.theclinics.com. If your medical center or hospital library does not carry the clinics, please encourage them to do so, as each issue offers comprehensive coverage of a major topic in otolaryngology head and neck surgery, often with extra materials available online. So let's proceed with the surgical techniques section of your clinics. A majority of parapharyngeal space tumors are salivary in origin. So Will, you and Dr. Larson looked at transoral approaches for these tumors, and you point out that the advent of TORS, which is transoral robotic surgery, as well as transoral endoscopy, has really expanded the indications for this. So what are the key advantages and disadvantages when you are counseling a patient and their family if they've got a ranula or some other salivary tumor that you're trying to approach through parapharyngeal space tumor that you're trying to approach through the mouth as compared to transcervical or transparotid approaches?
So there's a few advantages. The main ones I think are lack of a neck incision, lack of neck numbness, and then I think pretty much eliminates the risk of first bite syndrome, which is, a sympathetic interruption from the external carotid artery system that disinhibits the parotid gland from during its initial secretion and causes pain. By not having to go through any the pathways of the external carotid artery system transcervically, you avoid that problem, which can really be hard on patients. And actually, it does bring up the use of Botox again, though, because Botox actually works fairly well for that, I find. But it also, a transoral approach avoids problems with the other cranial nerves, mainly the hypoglossal nerve, which is in the approach of transcervical approach, or if it's a transparotid and transcervical approach, the facial nerve. But you have to select the patients appropriately. The article goes into that. The main candidate tumors for this are medial to the internal carotid artery specifically, smaller tumors, and not right at the skull base. Those are the main things. So I always look for this possibility. One of the reasons I included the article is that I still to this day get a number of surgeons I meet that aren't familiar with this approach or not comfortable with it. So I just think the more it's emphasized as an option, that again, select cases, it's a good idea, and it's appropriate for a salivary issue in the clinics, because it's 80% of these tumors will be salivary in origin, usually pleomorphic adenomas. It does bring up the issue of the robot and endoscope. So what those do, I think, is enhance visualization and can enhance the access in certain situations. But they still are just a tool and shouldn't be the main focus of the operation. The focus of the operation is do a tumor excision safely and then do it without spillage. And those, particularly the robot without its haptic feedback, can be a problem. So you need to not get cute and just use it as a tool when it's appropriate to use it.
I'm glad you mentioned the spillage, because I think it's so vital to take a single tumor pleomorphic and then have spillage and then just be chasing that forever.
Right.
So I appreciate, the robot, like anything else, is a tool. And when you don't think you're going to get the kind of tumor removal that you need, that's not the tool to use.
I mean, you can use it for half the case and then stop and use something else, or use an endoscope with it. It's just another set of technologies that can be helpful.
Thank you. So as we move forward, Drs. Bowers and Shaitkin provide a nice overview of mucoceles, sialoceles, and ranulas. So Boyd, we talked a bit about this transoral approach and pleomorphics, but what are your technical considerations when you're managing these sort of boggy, fluid-filled sialoceles and ranulas?
The article points out two things I think every otolaryngologist needs to know. One is that ranulas, which are the floor of mouth swellings, saliva collections, have been shown to arise from the sublingual gland. That is the source. And sometimes you can have a plunging ranula. That's one that extends into the neck that has no visible signs of being in the floor of mouth. And often I've seen patients come in having had their submandibular gland removed, But what do you know? They still have this plunging ranula. And the reason for that, there's little herniations in the mylohyoid muscle that allow this leakage from the sublingual gland to extend down into the neck. So whenever you see a ranula in the floor mouth or a plunging ranula in the neck, it is the sublingual gland. And the way to treat that, unfortunately, there's no way to repair the sublingual gland. You have to remove it, but you can remove it transorally. And for the component that's in the neck, all you need to do is aspirate it. It's not a true cyst. It doesn't have a wall. It's just a collection of saliva with a fibrotic surrounding. So I'll commonly use an ultrasound, get a needle in there, suck out all the saliva from the neck component, and then take out the sublingual gland. And that's been shown to have close to 100% cure with no recurrence. If you take out the wrong gland, or if you just incise the ranula and try to marsupialize it, you're going to have a recurrence. So that's one great thing this article points out. The other thing is sialocyls of the parotid gland, usually due to post-operative leakage from one of the salivary ducts or to post-traumatic issues to the ducts, almost always resolve with conservative measures. So that includes either aspiration, or if it's been post-op, you can reopen part of the wound and drain it, apply pressure dressing, anticholinergics, and do that for 2 to 3 weeks, and most of these will resolve. If they go into a more chronic phase, you can do an aspiration followed by Botox again. So we were talking a lot about Botox today, but it is very helpful to shut these glands down and allow that cavity to more or less, it's that potential space you're eliminating and allowing it to scar down so that, and give time for that duct to heal and scar. So it's very rare now to have to do a re-excision of glandular tissue or due to sialocyle. And we would suggest avoiding that if possible, because again, you're going to get into a situation where, especially if they've had a previous operation, where it's hard to identify nerve tissue and things are going to be very sticky.
I totally agree with Boyd about the sublingual gland issue. It comes up over and over again, where you see a transcervical incision, this pseudocyst was removed. I mean, sometimes it has a little fibrotic capsule, so it seems like it's a cyst, but it's not. It's just fluid that's escaped into a fascial plane, and you can remove the saliva transorally with a suction down through the space that's coming out, that's tracking through into the neck.
Yeah, I'm thinking if the listeners want, they can continue to listen, but frankly, that's the pearl, right? That's perfect, because you will help so many people by actually pausing and having a thought, right? And then seeing what it is that you actually have to do. I hope you guys continue to listen, because man, if that already happened this early in the game, we're going to do well. So, we're going to move on, but I'm going to stay with Boyd for a second. You wrote an article with Dr. Quiz, which is like the greatest name ever, on transoral sialolithotomy without endoscopes. The name of this issue is Modern Approaches to the Salivary Gland. So when and how do you just go back and say, I know what I'm doing, let me just get rid of this? More of an old-fashioned way, clearly with newfangled techniques. And you have a really nice flow chart about how you make your decisions in this article.
Well, thanks for giving Dr. Quiz a little shout out. She's now an intern at the University of Florida in otolaryngology. So look forward to hearing more from her in the future. But the main reason this article arose of treating stones without endoscopes is because I found that, I get a lot of referrals for salivary stones, but only about 1/3 of those stones can I fully extract using endoscopic techniques. Most of these stones require some sort of open technique. And I do believe that most general ear, nose, and throat doctors have the skill and knowledge to deal with a certain subset of stones that are fairly frequent. And I know that figure 1 in this article goes into some detail, but kind of the quick and dirty is that if you have a submandibular stone that's greater than 5 millimeters and is a single stone and is fixed, and what I mean by that is non-mobile, and you can feel it with your finger in the floor of mouth, that's a stone that can be easily extracted transorally by a cut down approach. You cut down on the stone, you open the duct, you remove the stone, and you can do a salad docoplasty. You just kind of sew the duct wall to the floor of mouth. Now, do you have to be familiar with anatomy? You do. There's the lingual nerve nearby. There's the sublingual gland. If you cut into that, you can get a ranula, which we just talked about. So you have to be familiar with the anatomy. But this is the approach that I use, and I've found that even though I have scopes, I've gone to this approach for that indication because I don't want to. These scopes are very fragile, and I don't want to break my equipment. So in these cases, I know where I'm going to need to do a cut down. I just go straight to it, and I get the stone out. And it's a 30-minute procedure.
I want to point out to our listeners that you have provided a video of your technique to accompany this article, and that's available at www.oto.theclinics.com. We talked a bit, Will, you mentioned that after parotidectomy, some funny things can happen to people. The patient may be left with a small or sizable cosmetic defect. They may be left with Frey's syndrome of post-gustatory sweating of the cheek skin. So although the surgery was necessary and successful, there is a negative effect on the patient's quality of life. And I think, yes, we have talked about Botox, but we've talked about it not in a cosmetic fashion. But there are certainly cosmetic implications to what we do in the cheek, in the upper neck, and the lower neck. One of the key signers of the Declaration of Independence was Caesar Rodney of Delaware, who I learned in preparation for this podcast, rode his horse for 18 hours, that whole distance from Wilmington, Delaware to Philadelphia, Pennsylvania, which now takes about 10 minutes if you stop for a cup of coffee, through the driving rain in order to cast the deciding vote for Delaware that we secede from Great Britain. He had parotid cancer. So every picture you see of him shows that his face is covered with this sort of bulky green handkerchief to cover his facial deformity. In this issue on the modern approach to salivary tumors, you've included two articles on avoiding or treating the potential cosmetic deformity that is possible after a successful parotid tumor resection. So let's talk about treating the defect. So Will, there's an article on soft tissue reconstruction of parotidectomy defects by Drs. Moy, Wax, and Loyo, and that discusses various techniques and offers a comprehensive table, Table 1, that looks at indications, pros, cons, and surgical tips, and actually looks at 15 different reconstructive options. Can you give us some highlights?
I'm glad you brought up Frey's syndrome because it's intertwined with all this. Unfortunately, it can be solved with reconstruction, or at least maybe even entirely. I think there's a bunch of options that were listed in that table. Personally, I use 3 mainly. I use a sternocleidomastoid advancement flap, and I do a superiorly based one, meaning that it's still attached to the mastoid. But I don't go through the entire sternocleidomastoid. I take half and make a back cut upwards, so then that part that's freed is then splayed out and covers the amount of parotid tissue as a bridge to the remaining parotid tissue, or at least the facial, the parotid fascia that's left over. And that does 2 things. It restores the contour. It pushes the earlobe outwards because it can be medially rotated. And I think that's the most noticeable thing. Gets sunken, the earlobe can be sunken in without the parotid, with the absence of the parotid. And then it appears to, based on multiple studies, to actually reduce the incidence of Frey syndrome. It probably blocks the parasympathetics that are deep in the remaining parotid bed from gaining access to the skin sweat glands. Now, I also use fat grafts. I like those less so, but I like them for cancer because I think the surveillance imaging shows the graft very well. Whereas this sternocleidomastoid muscle looks like a bunch of scar, and it's a little confusing to some radiologists. Fat can also be used a bit better in the sense of you can harvest the amount that you want and really tailor it to that patient. If there's a superior base tumor and you don't take inferior parotid, it's hard to get a muscle flap up to that superior part. So having a fat graft superiorly is nice. And the article talks about free flap reconstruction when there's a bigger defect, say radical parotidectomy or bone is removed, a temporal bone resection is done, and there's going to be radiation. And I think that's a suitable defect reconstruction for those situations. But all of them have, I think, certain situations where they can be used, and then certain surgeons have preferences for various reasons, and there's certainly overlap in all the aspects of this that I just mentioned. But I pretty much reconstruct every case.
So you never do even a superficial parotidectomy without putting tissue between the bed and the skin?
I pretty much always do. If there's a parotid tail tumor and not much parotid is taken, and there's not really a defect because it, you took a smidgen of salivary tissue and the tumor was really what you removed, then I don't reconstruct. But other than that, I always reconstruct.
That's interesting. How about you, Boyd? Do you do that as well?
No, I don't. I haven't made a habit out of it, but I certainly, it's interesting. I think this is a case where we for years gotten pretty good results, but not excellent results when we finally get around to talking to our patients. We tend to blow off things like Fry syndrome or how incision looks or a little sunken in area of the face, as long as, but when we really take a patient-centered approach and survey the patients, these things bother them, and often for many years. Part of the problem, I think, with these techniques, especially for the more routine partial parotidectomy recon, is that payers will often reject extra surgery fat grafts or dermal grafts or dermal substitutes, and because they consider these things cosmetic or not important. But I think we need to continue to, and it probably varies by area, but I've had patients stuck with big bills after I've done this because they wouldn't pay for the alloderm that I used in the case. So so I think that we have to advocate for our patients. I think we have to have good evidence to show that this does improve their quality of life and should be considered part of the procedure.
Very well said. You guys included an article not just on treating the defect, but also on preventing the defect. So you guys included an article called Cosmetic Approaches to Parotidectomy, and it's written by Drs. Kolayani and Richmond. And they focus on somewhat newer approaches to parotidectomy. They also have a nice table in there that compares 5 different minimally invasive approaches to the parotid. Parotids are removed for a number of cytologies, right? That we remove cancers, we remove pleomorphics, we remove lymphoepithelial lesions. So what should the parotidectomy surgeon or the otolaryngologist looking at the patient with a parotid lesion take from these cosmetic parotidectomy approaches?
Again, just kind of following up on the last discussion, the reason these approaches came about, these smaller incisions or better camouflage incisions, because patients want it. People want to look younger. They don't want someone being distracted and not look at their eyes and face by looking at a scar on the side of their face. So, I think that really it's a patient response to patient-driven care. But the modified Blair incision has been our mainstay for 80 years and been very successful. It gives excellent exposure and it gives a reasonable cosmetic result. If patients don't have those nice skin creases, if they're younger, And if they have tumors that are more inferior or in the tail of the gland, many of these are accessible through facelift approach or some of the other approaches mentioned in that table. There's a hairline retroauricular approach. There's even an endoscopic approach. So, but these are for experienced surgeons and people who are good at getting out these tumors without spillage, getting them out cleanly, and doing, obviously the most devastating thing for a patient cosmetically would be damage to the facial nerve. So if someone's not experienced with these, certainly the modified Blair, I think, is still the best approach. And that's really the approach I want my residents to leave their program knowing how to do very well. But if they are out in practice and doing a lot of parotidectomies, I consider a high volume surgeon somebody who does at least one a month, 1 to 2 a month. If you're doing that sort of volume and you want to offer, that extra to your patients, it is well appreciated by patients.
Thank you. I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and I am really enjoying this conversation with the guest editors of the June 2021 issue of Clinics, which is called Modern Approach to the Salivary Glands. My two guests on this podcast today are Dr. M. Boyd Gillespie of the University of Tennessee in Memphis, Tennessee, and Dr. William Ryan of the University of California at San Francisco in San Francisco, California. Let's go onwards to the last group of articles. Will, we've talked a lot about diagnosis and then a lot about surgery for both benign and malignant tumors. But in fact, there are benign tumors of the parotid gland that can be observed and can be sort of active observation rather than surgical intervention. There's an article on this written by Drs. Ringel and Kraus. What clues do you use cytopathologically, imaging-wise, etc., to determine that this is one that's reasonable for active observation?
I'm glad this article was written and is out there. I think it's an important part of salivary tumor care. I don't think all tumors need to be removed. I think there was a bit of a push for that years ago, and that it may be still a credo by some surgeons, but I think some can be observed. Cytology is very important for parotid tumors and some mandibular gland tumors, but there's degrees of confidence that cytopathologists have, just like they have with thyroid nodules, and so that degree of confidence plays into whether something can be observed or not, I think. And I think repeat biopsies can be helpful, but are usually not for salivary tumors, I've found. And I think there's decent data to say what I just said is true. So, but there are imaging characteristics, particularly in ultrasound, being more likely or more likely malignant, to help sway that decision towards surgery or observation. And then a patient's, then if a tumor is growing rapidly, it'd be more apt to remove surgically. And then the patient's age and comorbidity, I think, plays in this a lot. If the patient's 80 and has major health problems and appears to have an indeterminate tumor or probably benign, I think that's very reasonable to observe it. And it brings up ultrasound. Ultrasound is a good way to observe these in clinic quite quickly. That's something I do and have for my whole career. But MRI is a great tool as well, particularly if there's deep extent. So it depends, but there's a whole list in that article of benign tumors. I think all of them except for pleomorphic adenoma can be observed unless there's a cosmetic problem or discomfort to the patient. They should be surveilled because you're never quite sure with some of these cytologies, and you don't want to let it go too much.
Yeah, I was going to say that some of us on this podcast are slightly closer to 80 than you are. So maybe we'll use a different decade. Too old for surgery. But you're right. And they talk about this Milan system for reporting salivary gland cytopathology. They talk about using the American College of Surgeons Surgical Risk Calculator, and the World Health Organization histology classification of salivary tumors. And I think, vigilance is very important. And I think there is a great role for shared decision making with the patient and their family when you're going this route. I like what you mentioned about using in-office ultrasonography, harking back to the beginning of this podcast to follow these. I think that's a really cool use of modern technology. There's a condition called sialadenosis, and Doctors Davis and Hoffman gave a really thorough review on it in the next article. So Boyd, what is sialadenosis and why should the practicing otolaryngologist know about this?
Thank you. Yeah, I think it's an important topic, and luckily, Dr. Hoffman's one of the leading experts in this who wrote the article. But sialadenosis is a benign enlargement of the salivary glands. It's not related to tumor or inflammation. So, and what we have learned, and what I learned from reading this article, was that it is due mainly to metabolic causes. So that could be malnutrition, it can be alcoholism, it can be liver disease, it can be diabetes. Any of these conditions can cause obesity, even can cause it. So anything that throws off the body's metabolism can result in this. But all these conditions have in common a kind of a late stage neuropathy of the sympathetic nervous system, autonomic nervous system that goes to the glands. Normally, the sympathetic system causes less glandular function, but when you lose that sympathetic system, you have over activity in the parasympathetic system, which actually causes swelling and enlargement of this tissue. So these patients present to otolaryngologists because they get sent to us for possible tumors or other issues, and they just have big, thick, massive parotid glands and or submandibular glands. And generally, they're fairly asymptomatic, except for maybe some cosmetic concerns. So the otolaryngologist, the key thing pointed out in this article, we have to play a diagnostic role. So we get appropriate imaging, and we take a good history, and we may or may not do a biopsy to show the enlargement of the tissue, but that's really our role. The key is not to necessarily perform surgery on these patients, but educate your patient, educate them that they have underlying conditions that are causing this. This is a benign finding. They do not have a tumor, and that often addressing these underlying metabolic issues will result in normalization of the gland. So the key is really not to over-treat these patients, and that's why otolaryngologists need to be aware of this disorder.
Thank you. So we've now reached the third section of the issue of otolaryngologic clinics of North America on modern approach to the salivary glands. And this third section is on salivary malignancy. And you've included 3 articles in this section. So let's start with the one by Doctors Wei, Kang, and Ha. And this really looks at molecular markers and how much they do matter when we look at salivary malignancies. So they talk about the tyrosine kinase pathway that affects many different receptors, including c-KIT, epidermal and human epidermal growth factor, vascular endothelial growth factor, VEGF, and fibroblast growth factor, FGF receptors. Then there are agents looking at targeting these individual receptors as well as multiple kinase inhibitors. And then the authors also teach us about the androgen receptor axis and the Notch signaling pathway and programmed cell death protein 1. So Will, very interesting, really educational article. But do these markers actually matter in clinical practice? And if so, how are you using them?
Great question. These hold some promise, patients, I think, but I think at a baseline, it's good to remember that surgery up front and when advanced, followed by radiation, is the best treatment for most salivary cancers. When these can play a role is when there's unresectable disease and or distant metastases. And I think of all the ones that were listed and described, the few that have most promise are the HER2 and the androgen receptor, and then VEG for salivary duct carcinomas, and then VEGF for adenoid cystic carcinoma. I think there's reasonably good data of some promise of some effect, probably partial effect or stabilization, and then sometimes there's a kind of a miracle situation for some of these patients. I've seen a few of these happen. We as surgeons need to be aware of these potential options. Obviously, these are given and the care is given by medical oncologists, and so their expertise is needed. But it's good to, I think it was good that we included this article because I think some people might not be aware of some of these options for certain situations. And then it just shows promise in the future as more things are evaluated, other receptors or other tyrosine kinase receptors or combination drugs. Maybe there will be certain scenarios where these work even better. But with all that, something I try to remind my patients is that if they're in a seemingly terminal situation, it's still okay to say no, continued treatment, because there are side effects with these. And so I think a meeting with medical oncologists is important, but for them not to feel too pressured and live the life they want to live towards in their last few days. Because a lot of these will not work very long. Presented in the article does show that the durability is not very long for many of these.
Right. And so let's say you're doing a tumor resection. Is there a special way you send the specimen so that these factors can be analyzed, if only for research or potentially to help the patient if that's the route?
Yeah, it's a great question. So these are all discovered by immunohistochemistry, basically. So, and that can be done later or at the time of initial evaluation. It can be done on even slides from other institutions a lot of the time if there's adequate specimens. So we talk about these in our tumor board. I mean, sometimes you don't know what the cancer is going to be. I mean, it looks like carcinoma, let's say, or sometimes it's a low-grade neoplasm and you don't know what it is, and it turns out it is a cancer. I mean, those situations usually you don't need to add a targeted agent, but sometimes with salivary duct carcinoma, it retroactively or later it recurs, let's say a year later, and you have the initial parotidectomy specimen and neck dissection. You can analyze that tissue then and see if it has targetable receptors that these agents could work well with.
Thank you. And I'm glad you talked about patient sovereignty and decision making. And I think, we didn't discuss this very much in my training. We talked a lot about these different tumors, but I think as we have matured as otolaryngologists, we understand that actually palliative care is very honorable care and very respectful care. So I'm glad that you mentioned that, because I think we all have to keep in mind the entirety of the patient as we are treating them within their family and community structure. There's a really interesting article about minor salivary gland tumors that you guys included. There are between 400 and 700 minor salivary glands throughout the upper aerodigestive tract. And fortunately, minor salivary gland tumors themselves are sort of rare, and malignancies of the minor salivary glands are quite rare, but they do occur. The tumor staging system and the pathologies are very similar or the same as those affecting the major salivary glands. Risk factors include tobacco and alcohol use, prior head and neck radiation, a history of any cancer, and a history of or presence of HIV infection. So in this article on minor salivary glands, Drs. Walvaker and Falke discuss the presentation and management of minor salivary gland carcinoma. Boyd, how many of these come to the ear, nose, and throat surgeon's attention from the dentist or the oral surgeon, and how do we optimize the care of these patients?
That's a great question, Sujana. The article does a great job of talking about the rarity of these, and they are rare. I work with a comprehensive head and neck team, and we may see 2 or 3 of these a year, maybe 5 in a busy year. Most otolaryngologists may see 2 or 3 in a career, but we have to be aware of them. And the reason we have to be aware of them is that the presentation of these tumors are so indolent. They can occur anywhere from the nasal cavity to the larynx or trachea, and they present as submucosal swelling. So they look quite benign, and they're easily misdiagnosed as a lipoma or salicil or cyst. And that leads to potential misadventures of people to go in trying to cut things out without knowing what they are. So whenever there's a submucosal swelling in the head and neck, this should be on the differential diagnosis as a potential cause. And the reason it's important, 80% of minor salivary gland tumors are malignant. So if there is a submucosal swelling, it's important to get appropriate imaging. It's appropriate to get a tissue diagnosis, either with FNA or core needle biopsy, before you start to embark on care. And then if it is malignant, these patients definitely need to be presented to a multidisciplinary tumor board. And then the plan should be for a comprehensive, full excision, because this article really points out that your ability to cure these patients is really your best chance is your first chance, and that's the full excision. And they're always going to be adjacent to critical structures, nerves, blood vessels, the mandible or the bony skeleton of the head and neck. So you have to have a plan of what you're going to remove in order to get clear margins on this. And then certainly radiation therapy plays a role as an adjunct to that surgical excision. But some of the lower grade ones, surgical excision alone, if done well the first time, may be enough to treat the patient without radiation. And that really saves a lot of morbidity. But the article goes into the different subtypes, which there are many, and their behavior is somewhat different, but it does a great job of just keeping in mind this as part of your differential diagnosis.
I mentioned the dentist or the oral surgeon. Is chewing tobacco sort of give you a predilection for this kind of tumor, or is it just happens sometimes?
I have not seen a direct. I probably live in a place that chews more tobacco than you guys in Memphis. We haven't seen a lot of that. There was a baseball player who played for the Padres. I'm blanking on his name right now. Maybe
Tony Gwynn.
Yeah, Tony Gwynn, who was a Hall of Famer who died of salivary gland cancer, and he attributed that to his chewing tobacco use. And my feeling is that I kind of let that message stand because I don't want people chewing tobacco. So it's just better to have people scared of it. But if you're really going to get down to causation, I think it's looser and it's a looser association.
So I'm in New York, but ethnically I'm from India. And, we do crazy stuff in India, apparently. We chew betel nut, which is quite delicious once you get over the fact that it's gross. It's quite nice. But I certainly don't put nicotine or I don't put tobacco in my betel nut when I chew it. There are people who actually put little shards of glass in the betel nut to sort of penetrate the mucosa, so the nicotine, actually the tobacco product, feeling is better. Apparently we reverse smoke our hand-rolled cigarettes, which is also very bizarre. But you're right, we don't see this sort of plethora of minor salivary gland tumors emerging from this. We do see head and neck cancer emerging from this, but we don't.
Yeah, India, unfortunately, is the #1 site for oral cancer in the world, and largely for those reasons you mentioned. But most of it's squamous cell. So you're right. You would think that if there was a strong connection with minor salivary glands, you would see that have a higher rate in that country than maybe others. And I don't think there's evidence for that. Do you know, Will?
It can't help. It can't help.
You feel that chewing on glass and tobacco and then
Any
reverse
chronic inflammation around human tissue
is probably not a
may
great
lead
idea.
to cancer. That's I think the general theme that we see with Alzheimer's.
Yeah, thank you. So we have come to the final article in your absolutely terrific issue of Otolaryngologic Clinics of North America on modern approach to the salivary glands. And in this final article, Doctors Kainer and Harris review the role of neck dissection in salivary gland malignancy. Table 1 in this article breaks down the incidence and level of occult metastases in various salivary gland tumors. If you're studying for your boards or you just want to look smart, it's a good table to look at. And figure 4 gives a flow chart of how to decide whether or not to do an elective neck dissection in these patients. So, Will, why is the proper management of the neck critical for patient care in salivary gland malignancies?
Well, I think the article goes into just the propensity of these certain tumors to transmit regional metastases, and certainly if there's a lymph node metastasis present at the presentation of the patient, it should be addressed, because we know surgery up front followed by radiation has the best chance of cure. And then the real question is whether to do an elective neck dissection or prophylactic neck dissection for these situations. It's not really super clear from the evidence that exists. The biggest problem with salivary gland cancers is that there are so many. First of all, they're rare anyway, and there's so many of them. So all the studies always group them, and so there's this limitation present no matter what. That maybe for some it's not necessary for others, but I think it boils down to, generally, in the article talks about this, that likely in high grade cancers, if you know ahead of time, which you don't always, and in advanced T stages, T3, T4, or if the nerves involved, there's facial nerve paralysis, say, that an elective neck dissection is likely going to help that patient. And I think you'll find nodes, and then you've removed them, and that's probably a win for the patient. And then radiation can be applied. It also helps, I think, define the radiation fields. If it's a pathologic N0 neck, the dose of that to that neck can be reduced significantly or even eliminated with some radiation oncologists. It depends on who they end up with. So that can sometimes bring benefit to the patient. And I think for the most part, the extent of neck dissections and the expertise of surgeons that do neck sections regularly, the morbidity of a neck section is really not very bad if done well. And so it brings staging information to the patient. It can be therapeutic. It can help with guiding radiation.
Boyd, is there a consequence to mismanaging the neck in these salivary gland malignancies?
Yeah, I think it's really a double-edged sword. And I think figure 4 in this article is excellent. I really like how they took the evidence and try to boil it down into that figure. But it's a double-edged sword because you can either do too little and miss the opportunity when you're resecting the tumor to do a regional neck dissection. And they really point out there's certain histopathologies where neck dissection should just be part of the resection. And certainly late stage disease, it should be part of and that's, T3, T4, or nerve involvement or extraparenchymal spread. So, but the other side of the sword is doing doing too much. And you can do too much and leave a patient with a weak shoulder and fibrosis and scarring. And patients don't like that either. And it's bad long-term. So there's, the key to all this, really, the driving thing's pathology and getting your pathology early and repeating it if necessary, and just really having trust in a cytopathologist. And if you don't have one on site that you can trust, have them ship it out for a second opinion. And there's time. Most of these tumors aren't progressing at a rapid clip, but you have a few weeks to try to get yourself an answer and come up with the proper plan. Because again, the first crack at treatment is going to be your best chance at long-term cure. And if it's not done well, it's hard to catch up and salvage it with alternative techniques.
I want to thank you both for joining me today. I want to let our listeners know that the June 2021 issue of Otolaryngologic Clinics of North America contains 2 more articles in the special series Intentionally Shaping the Future of Otolaryngology, which was guest edited by Dr. Jennifer Vilwalk from the University of Kansas Medical Center, Department of Otolaryngology. Those 2 articles are Diversifying Researchers and Funding in Otolaryngology by Drs. Fang, Borinsky, Gray, Brades, Chandrasekhar, and Eloy, and Critical Components of Diversity Initiatives by Drs. Isianor, Klusterman, Cabrera Muffley, Brown, and Vinson. That series began in the August 2020 issue of Clinics and concluded in the August 2021 issue of Clinics. And you can find 2 articles of each of that series in each of those intervening issues, except for the December 2020 issue of Clinics, which had special articles relating to COVID-19 and otolaryngology. You can find the podcast of my conversation with Dr. Vilwalk at www.oto.theclinics.com or wherever you get your podcasts. Boyd and Will, again, thank you so much for taking the time and effort to compile the June 2021 issue of Otolaryngologic Clinics of North America on modern approach to the salivary glands. You identified and invited the authors who are leaders in this space and have been really generous in synthesizing a lot of information in a way that all of us can understand it and can better treat our patients with it. And then you spent this really, for me, a lot of fun time recording this podcast. So thank you. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. And today I've been speaking with Drs. M. Boyd Gillespie, professor and chair of otolaryngology head and neck surgery at the University of Tennessee Health Science Center in Memphis, Tennessee, and Dr. William Ryan, who is associate professor, head and neck oncologic, endocrine, and salivary surgery in the Department of Otolaryngology head and neck surgery at UC San Francisco in San Francisco, California. You can find all the issues and podcasts at the website, which is oto.theclinics.com, in your medical libraries and wherever you get your podcasts. Please let us know how we can improve on the issues and the podcasts. Thank you so much for listening and reading, and thank you so much, Will and Boyd, for spending this time with me.
Thank you.
Thanks, Sujana.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on modern approach to the salivary glands, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast on Apple Podcasts and Google Play.